Prenatal care refers to evaluations that can be done during pregnancy to assess maternal and fetal health, and intervene when possible to ensure the birth of a healthy baby with minimal risk for the mother. Prenatal care also includes preconception counseling, which seeks to identify a spectrum of social, behavioral, environmental, and biomedical risks for a woman's fertility and pregnancy outcome, with the goal of reducing these risks through education, counseling, and appropriate intervention. Now, pregnancy consists of 3 trimesters, the first lasting for the first 12 weeks of pregnancy, the second between weeks 13 and 27, and the third from weeks 28 to 40. And during each of these trimesters, the obstetrical consult focuses on different aspects of maternal and fetal health. Prenatal visits are usually done every 4 weeks until week 28, every 2 weeks from week 28 to 36, and then weekly until delivery. So, the initial prenatal visit may occur either when the individual suspects that they are pregnant or because they wish to conceive in the near future. No matter the case, at the initial prenatal visit, the focus should be on obstetrical history, family history, and identifying any potential risks during pregnancy. The obstetrical history comprises of gravidity, parity, and abortions. Gravidity, or G, means the number of times the individual has been pregnant so far, including the current pregnancy. Parity, or P, refers to the number of times the individual has carried the pregnancy to a viable gestational age, meaning more than 24 weeks. Finally, abortions, or A, refers to the number of pregnancies that were lost for any reason. So, for example, if the individual is currently pregnant, has been pregnant once before, and that pregnancy resulted in a live birth at 38 weeks, you'd say that as gravida 2, para 1, abortion 0, or G2, P1, A0. Alternatively, if that previous pregnancy had resulted in a miscarriage at 12 weeks, you'd say that as G2, P0, A1. Also, a detailed family history with a focus on genetic condition should also be obtained. In some individuals, genetic counseling and genetic carrier screening is indicated before conception. For example, when there's a strong family history of cystic fibrosis or sickle cell disease, individuals can benefit from genetic testing to see if they and/or their partner have the mutation, and genetic counseling could help them make the best reproductive decision. Genetic counseling is also recommended in inbred families, as autosomal recessive disorders are more frequent in these situations. The rest of the history focuses on identifying and correcting any potential risks, such as chronic medical problems like diabetes, hypertension, or epilepsy, mental health disorders like depression, and use of medications known to be teratogenic, such as valproic acid, isotretinoin, or some dietary supplements. Information about lifestyle factors like nutrition, exercise, and the use of tobacco, alcohol, or illicit drugs, and environmental concerns like mercury, lead, or pesticide exposure at home or at work should also be assessed. Finally, social concerns like the possibility of domestic abuse, as well as other potential barriers to care, like remote living and economic constraints, should be identified and addressed. Core interventions that can be done to minimize maternal and fetal risk following this step are to stop teratogenic medications, like isotretinoin, or switch to a less harmful alternative in case of chronic health conditions. For example, for individuals with hypertension, antihypertensives that can be used during pregnancy include labetalol, methyldopa, or calcium channel blockers like nifedipine. Seizure control in individuals with epilepsy can be achieved with lamotrigine or levetiracetam, which provide adequate seizure control without teratogenic risk. And in individuals with diabetes, oral medications like glyburide or metformin are indicated, or the individual can switch from oral medications to insulin. Finally, folic acid supplementation with 0.4 milligrams per day is indicated to prevent neural tube defects, or NTDs, in the fetus. This can be done as early as 3 months preconception, but if the initial prenatal visit occurs when the individual is already pregnant, supplementation should start on the day of the visit and continue throughout the pregnancy. In individuals who are at a higher risk of having a child with NTDs, like those who've had a previous pregnancy with NTDs, a family history of NTDs, or those who are using valproic acid, higher doses of up to 4 milligrams per day are recommended for the first 12 weeks of pregnancy, and the dose can be lowered to 0.4 milligrams for the rest of pregnancy. Next, both a physical exam and a laboratory evaluation should be done in both a preconception setting, and if the individual suspects they are pregnant. The body mass index, or BMI, should also be calculated, and weight loss or weight gain should be recommended in individuals with a BMI over 25 or under 18.5. The general physical exam focuses on the heart, breasts, thyroid, lungs, and abdomen, as well as blood pressure measurement, to screen some of the most common conditions that can affect pregnancy outcome, like hypertension, thyroid disorders, or genital issues. The laboratory evaluation comprises of establishing a baseline hemoglobin and hematocrit, determining the individual's blood group and Rh status, and screening for infections, and, in some cases, screening for other diseases that could have an adverse impact on the fetus, like diabetes. Specifically, a blood sample is taken to screen for infections like HIV, syphilis, and viral hepatitis, and to document immunity against diseases like rubella and varicella. If a sexually transmitted infection is diagnosed, treatment should be initiated immediately. Likewise, if there are low IgG antibody titers against rubella virus and varicella zoster virus, vaccination should be done before pregnancy. And that's because these are live attenuated vaccines, and they may cause adverse effects to the fetus if given during pregnancy. Additionally, pregnancy should be postponed for 1 to 3 months following vaccination. If low antibody titers are found during pregnancy, vaccination is postponed until after the pregnancy. Finally, screening for diabetes with a fasting blood glucose level and glycosylated hemoglobin is recommended in individuals with risk factors for diabetes, like age over 40, a body mass index greater than 25 kilograms per meter squared, a previous HbA1c level in the pre-diabetes range, or a history of dyslipidemia and hypertension. A urine sample should also be sent for urinalysis and urine culture to rule out asymptomatic bacteriuria or a urinary tract infection, both of which are common during pregnancy and should be treated if found. A full pelvic exam should be done, including an ultrasound to look for any anatomic abnormalities, like uterine fibroids, that may complicate the pregnancy, as well as a pap smear to screen for cervical cancer, if one hasn't been done in the past 3 years. Cervical swabs are also taken to screen for chlamydia and gonorrhea. In individuals who suspect they are pregnant, like if they missed their last menstrual period, or if they've had a positive urine pregnancy test at home, pregnancy should be confirmed with a urine pregnancy test and a transvaginal ultrasound. The earliest visible sign of pregnancy is the presence of an anechoic gestational sac, which looks like a tiny black bubble, and can be detected as early as 3 to 5 weeks after the last missed period. Next, the estimated date of delivery, or EDD, should be calculated based on the first day of the last menstrual period, or LMP. There are a lot of apps and online calculators that do this for you, but a simple way to calculate it yourself is to use Nagela's rule, which says that the EDD is the first day of the LMP, plus 1 year, minus 3 months, plus 7 days. All this math adds up to about 280 days of gestation. So, for example, if the first day of the LMP was May 4th, 2019, the estimated date of delivery is May 4th, 2019, plus 1 year, so May 4th, 2020, minus 3 months, so February 4th, plus 7 days. So the EDD is February 11th, 2020. In individuals with irregular menses, or if the first day of the last menstrual period is unknown, the ultrasound can determine the gestational age, based on the crown to rump length, which means how long the embryo is. Then, the gestational age can be used to determine the estimated date of delivery. The ultrasound can also distinguish between single and multiple gestations, and rule out ectopic pregnancy, which is when the fetus implants somewhere other than the uterine cavity, most frequently in the fallopian tube, and a molar pregnancy, which results from errors in normal fertilization and leads to the formation of an abnormal placenta and no fetus. Okay, now aside from genetic carrier screening, there are other tests that can be done to screen for fetal aneuploidies, which means chromosome number abnormalities. The most common aneuploidies are Down syndrome, Edwards syndrome, and Fetal syndrome, which are also called trisomy 21, 18, and 13. During the first trimester, the combined test can be done, usually between weeks 10 and 13. This test includes an ultrasound nuchal scan, or nuchal translucency scan, which measures the sonographic thickness of the fluid under the fetus's neck, and measuring serum levels of pregnancy-associated plasma protein A, or PAPPA levels for short, and serum levels of free beta-HCG. Based on this test, the risk category is established for each of the aneuploidies. When nuchal translucency, or NT for short, is very large, more than 4 millimeters, and PAPPA levels are very low, and serum free beta-HCG is high, that means high risk for Down syndrome. When nuchal translucency is very increased, PAPP levels are very low, and free beta-HCG is low, that's high risk for trisomy 18. Finally, when nuchal translucency is increased, but not quite as much as with Downs, and PAPP and free beta-HCG levels are very low and low, that's high risk for trisomy 13. During the second trimester, screening was classically done with the triple test, which measured serum levels of serum alpha fetoprotein, or AFP, unconjugated estradiol, or UE3, and free beta-HCG. Nowadays, the quadruple test is performed, which is the same as the triple test, but also includes inhibin A levels. The quadruple test is usually done between weeks 15 and 18. When all are decreased and free beta-HCG is unchanged, that's high risk for Down syndrome. When AFP is low, UE3 and free beta-HCG are very low, and inhibin A levels are unchanged, that's high risk for trisomy 18. Finally, when all levels are unchanged, that could mean trisomy 13, in the context of high-risk first trimester screening results. Now, an alternative to these classic screening tests is the assessment of cell-free DNA in a maternal blood sample. This is basically fetal DNA from mom's blood, and can be analyzed as early as 10 weeks of gestation to determine the risk of fetal aneuploidies. It's important to note that these tests don't diagnose an aneuploidy, but rather establish if there's a high risk for it. Regardless of which screening test was done, an invasive procedure like chorionic villus sampling between weeks 10 and 13, or amniocentesis between weeks 15 and 18, with subsequent fetal karyotyping, is considered the gold standard diagnostic test, and it's recommended for individuals in the high-risk group, especially those who are considering termination of the pregnancy in case of a positive result. Notably, these invasive procedures come with a risk of fetal loss between 1 in 300 and 1 in 200. Finally, a special mention regarding screening tests is that high maternal serum AFP levels could suggest a high risk of neural tube defects in the fetus. These include anencephaly, which is when a large part of the brain, skull, and scalp doesn't form during fetal development, encephalocele, which is when the brain and the meninges herniate through an opening in the skull, and spina bifida, which is when the vertebrae and the membranes around the spinal cord don't close, or close incompletely during fetal development. Okay, now let's switch gears and look at second trimester investigations. Until week 24, the most important part of prenatal evaluations, aside from genetic screening and routine investigations like blood pressure, hemoglobin and hematocrit, and a urinalysis and urine culture, is the obstetric ultrasound. Between weeks 18 and 22, the ultrasound focuses on detecting fetal abnormalities, like renal defects, for example. An ultrasound can also diagnose cervical insufficiency, which is when there's a cervical dilation and effacement, which means thinning, too early in the pregnancy. This translates as a cervical length on ultrasound less than 25 millimeters, and carries an increased risk of second trimester pregnancy losses or preterm births. Cervical insufficiency is treated with cervical cerclage, which is when a strong suture is sewn into and around the cervix, and this is done before week 24. At the prenatal visits before weeks 24 and 28, things get a bit more specific. So, we're still measuring hemoglobin and hematocrit to screen for anemia, and measuring blood pressure to look for the possible onset of a hypertensive disorder of pregnancy, like preeclampsia. Urine samples are analyzed for asymptomatic bacteriuria, or for a urinary tract infection, but now it's also important to start looking for proteinuria, which is consistent with preeclampsia. And of course, we're still doing an ultrasound at every visit to assess fetal growth and amniotic fluid levels. Finally, starting with week 28, screening for gestational diabetes mellitus, anti-D antibodies in Rh-negative individuals, and also for fetal anemia in the context of possible alloimmunization is also done. Screening for gestational diabetes is done with a 50-gram, 1-hour oral glucose test. That's when 50 grams of glucose are given orally, and blood sugar is measured on a venous blood sample drawn 1 hour later. If blood sugar after 1 hour is higher than 135 to 140 milligrams per deciliter, that's considered a positive screen, and either a 75-gram 2-hour or a 100-gram 3-hour glucose tolerance test can be given to confirm the diagnosis. With the 2-hour test, serum glucose levels are measured before glucose administration, and 1 to 2 hours after. And with the 3-hour test, one more measurement is done. Gestational diabetes mellitus is confirmed when there's at least one elevated blood sugar measurement with the 2-hour test, and at least 2 elevated measurements with the 3-hour test. Treatment is done with medical nutritional therapy, and a whole lot of math goes into this. So first, the recommended caloric intake is calculated, depending on present weight. Individuals with weight in the normal range during pregnancy need 30 kilocalories per kilogram per day. Individuals who are underweight should consume 35 to 40 kilocalories per kilogram per day. And overweight individuals need 22 to 25 kilocalories per kilogram per day. Finally, severely obese individuals need 12 to 14 kilocalories per kilogram per day, but should still consume a minimum of 1,800 kilocalories per day. So a 70 kilogram individual who is within the normal weight range should consume 2,100 kilocalories per kilogram per day. 40% of these calories should be carbohydrates, mainly those found in low glycemic index foods, like fruits, vegetables, and whole grains. Flour-based products like bread should be avoided. Protein should amount for 20% of daily calories, and fats for the remaining 40%. Blood sugar is measured before and after meals, and adjustments are made, particularly regarding carbohydrate amount and type, depending on blood sugar levels. Exercise is also indicated if there are no obstetrical contraindications to physical effort, and if that doesn't control blood sugar levels, anti-hyperglycemic treatment can be done with insulin or oral anti-hyperglycemics like glyburide or metformin. Screening for anti-D antibodies is done at 28 weeks in Rh-negative individuals, meaning they don't have the D antigen on their red blood cells, who have been pregnant before, and who are now pregnant with a fetus conceived with an Rh-positive or Rh-unknown individual. The reasoning behind this is the previous pregnancy may have been with an Rh-positive fetus, and that induced the formation of maternal anti-D antibodies at the time of childbirth. An indirect Coombs test is done to assess for the presence of anti-D antibodies. If they're absent, that's called a negative indirect Coombs test, and if they're present, that's called a positive indirect Coombs test, and the individual is considered alloimmunized. In Rh-negative individuals with a negative indirect Coombs test, the goal is to prevent alloimmunization by administering anti-D antibodies immunoglobulin G, or IgG. Anti-D IgG basically binds to the maternal anti-D antibodies and doesn't allow them to attack the fetal red blood cells. The standard regimen is 300 micrograms of anti-D IgG given intramuscularly between 26 and 30 weeks gestation, and another dose given postpartum within 72 hours of delivery. If the fetus is confirmed to be Rh negative following delivery, the second dose can be omitted. In Rh negative individuals with a positive indirect Coombs test, the antibody titer is determined, and if it's higher than 1 to 16, that means there's a large number of these antibodies that may attack the fetal red blood cells and cause fetal anemia. So, to assess fetal status, middle cerebral artery peak systolic velocity, or MCA-PSV, is assessed through transcranial Doppler ultrasonography. The basis for this is that the fetal hemoglobin levels determine the velocity of blood flow through the middle cerebral artery. So the lower the fetal hemoglobin, or the more severely anemic the fetus is, the higher the MCA-PSV will be. MCA-PSV values are expressed as multiples of the median, or MOM, and a value higher than 1.5 MOM may indicate moderate to severe fetal anemia. In this case, fetal blood sampling is done to determine fetal hemoglobin levels. The most commonly used method to sample fetal blood is through chordocentesis, also known as percutaneous umbilical blood sampling, which is when a needle is inserted into the umbilical cord under ultrasound guidance to get a blood sample. If fetal hematocrit is less than 30%, or fetal hemoglobin is 2 standard deviations below the mean value for gestational age, the same technique done for percutaneous umbilical blood sampling can be used to perform intrauterine blood transfusions, which are done every 1 to 4 weeks until the fetus is mature enough for delivery, usually between 34 and 36 weeks gestation. Now, if that all sounded a bit science fiction-y, luckily the last part of prenatal care rings a bit closer to home. So, between 28 and 36 weeks gestation, remember that prenatal visits are scheduled every 2 weeks, and at each one, blood pressure is measured, as well as hemoglobin and hematocrit, and a urinalysis and urine culture are still done to look for asymptomatic bacteriuria, urinary tract infections, and proteinuria. Ultrasounds are performed at each visit to assess fetal growth and amniotic fluid level. Also, as the term is approaching, the ultrasound can assess fetal lie and presentation. Fetal lie means the relationship of the long axis of the fetus with respect to the long axis of the mother, while fetal presentation means what part of the fetus is right above the cervix. The most common fetal lie and presentation is longitudinal cephalic, which means the fetal long axis is parallel to the mother's long axis, and the presenting part is the fetal head. So basically, baby's coming out head first. But sometimes the fetus may lie longitudinal, but in a breech presentation, meaning their buttocks are in the presenting part. This can make vaginal delivery difficult, and in some cases even require a C-section. So when caught between the 36-week ultrasound, a maneuver called external cephalic version can be done. That's when one hand is placed on the uterine fundus, right where the fetal head is, and the other one is on the lower segment of the uterus, on the fetus's buttocks. Then, the fetus can be turned from breech to cephalic presentation. Finally, starting with 32 weeks gestation, fetal surveillance can also be initiated in high-risk pregnancies, or if the individual detects decreased fetal movement at any point. High-risk factors include diabetes mellitus, hypertensive disorders of pregnancy, like preeclampsia, fetal growth restriction detected on ultrasound, twin pregnancies, and post-term pregnancies, meaning beyond 40 weeks gestation. Commonly used fetal surveillance methods include a non-stress test, or NST, and a biophysical profile, or BPP. An NST is a 20-minute recording of fetal heart rate using a cardiotocograph, also called an electronic fetal monitor. On a normal NST, fetal heart rate varies between 110 and 160 beats per minute, and has at least 2 accelerations, defined as increases of 15 beats per minute in fetal heart rate, lasting for more than 15 seconds. A lower heart rate, fewer or shorter accelerations mean the NST is non-reactive and warrants a biophysical profile, or a BPP. A biophysical profile is an evaluation of the fetus that's scored based on 5 criteria. The first criterion is the NST result. The other 4 are fetal breathing movements, fetal torso and limb movements, muscle tone, and the amount of amniotic fluid, and all 4 of these are evaluated on an ultrasound. 2 points are awarded for each of the 5 criteria, adding up to a maximum of 10 points, and the higher the score, the better. And 6 out of 10 or above is considered a good score, which signifies the fetus is generally doing well. Additional tests that are done after 28 weeks are evaluation of Group B streptococcus, or GBS, status, and sometimes retesting for sexually transmitted infections, or STIs. Some individuals may be colonized with GBS, which can cause neonatal meningitis following vaginal delivery. So, to evaluate GBS status, vaginal and rectal swabs are sent for culture. In GBS-positive individuals, ampicillin should be given at the time of delivery. Retesting for STIs at 28 weeks is recommended for individuals who've been diagnosed with an STI earlier in pregnancy, or in those who are at a high risk of getting one, like those who don't use condoms and have multiple concurrent sex partners. And finally, after 36 weeks, prenatal visits are scheduled weekly until delivery, to assess changes in fetal lie and presentation in preparation for delivery. The core of prenatal care for this gestational age is to determine if there are any contraindications for vaginal delivery, like disproportion between fetal size and maternal pelvis, and to counsel the individual regarding labor, like choosing a birthing plan, or explaining their options for managing labor pain, and also counseling about the postpartum period, like postpartum complications, postpartum contraception, and breastfeeding. Alright, as a quick recap, prenatal visits are usually done every 4 weeks until week 28, every 2 weeks from weeks 28 to 36, and then weekly until delivery. The initial prenatal visit should be focused on obstetrical history, family history, as well as identifying any potential risks during pregnancy. Folic acid supplementation is started to prevent neural tube defects, and teratogenic medications are stopped or switched for less harmful alternatives. A physical exam and lab studies are also done, including blood pressure measurement, hemoglobin and hematocrit levels, ABO and Rh blood type, and a urinalysis and urine culture are done, as well as screening for sexually transmitted infections and assessing immunity against rubella and varicella. In pregnant individuals, the estimated date of delivery, or EDD, can be calculated using Negala's rule, by adding 1 year to the first day of the last menstrual period, or LMP, then subtracting 3 months and adding 7 days. Additionally, an ultrasound can be done to measure the crown rump length to determine the gestational age. Screening for aneuploidies can be done with a combined test in the first trimester, which includes a nuchal translucency scan and serum levels of PAPPA and free beta-HCG. In the second trimester, weeks 13 to 28, screening can be done with the triple test, which measures serum levels of serum alpha-fetoprotein, unconjugated estradiol, and free beta-HCG, or the quadruple test, which is like the triple test but also measures serum inhibin A. An alternative to these tests is measuring serum cell-free DNA as early as 10 weeks gestation. Regardless of which screening test was done, an invasive procedure like chorionic villus sampling between weeks 10 and 13, or amniocentesis between weeks 15 and 18, with subsequent fetal karyotyping, is considered the gold standard diagnostic test. Until week 24, cervical insufficiency can be diagnosed on an ultrasound, and cervical cerclage can be done to prevent preterm birth. Between weeks 24 and 28, fetal growth and amniotic fluid are measured on an ultrasound, and screening for hypertensive disorders of pregnancy is done by measuring blood pressure and looking for proteinuria at each visit. Starting with week 28, screening for gestational diabetes mellitus, anti-D antibodies in Rh-negative individuals, and fetal anemia in the context of possible alloimmunization is also done. Between weeks 28 and 36, fetal lie and presentation is assessed with an ultrasound. An external cephalic version may be done for breech presentations.